Good evening, everyone. Welcome to the second session of the mini medical school, The Heart of Health. I'm Dr. Forum Kamdar. I'm a heart failure cardiologist and associate professor of medicine in the cardiovascular division at the University of Minnesota Medical School. We're excited to have all of you here today, and we look forward to guiding you in the heart of health. The second topic in the series is the heart and the body, interconnected health. We will begin with a moderated discussion followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. Please note that this session is being recorded and will be available later this week on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email. Today, we have the privilege of speaking with a panel of leading experts in cardiovascular care at the University of Minnesota on the crucial role the heart plays in the health of multiple body systems. I'd like to introduce our panelists. First, I'd like to introduce Dr. Linyi Chen. Dr. Chen is a professor of medicine in the cardiovascular division at the University of Minnesota Medical School. He is a cardiologist and a cardiac electrophysiologist. He is the director of the Lillehei Heart Institute, a research institute whose mission it is to discover novel strategies to promote cardiovascular health and reduce suffering from cardiovascular disease. Welcome, Dr. Chen. Can you discuss heart problems, stroke, and dementia?
Thank you very much, Forum. Good afternoon, everyone. My name is Linyi Chen, and I'm the director of the Lillehei Heart Institute at the University of Minnesota. Today, it is my pleasure to talk about heart problems and how they relate to stroke and dementia. Other than grants from the NIH that fund my research on heart rhythm disorders and atrial myopathy, I have no other disclosures. In the next 20 minutes or so, we will touch on the following. We will start by recognizing that heart conditions or heart disease are risk factors for stroke and dementia. Next, we will focus on atrial fibrillation, a very common heart rhythm disorder, and appreciate that it is associated with stroke and dementia. Then we will take a deep dive into atrial myopathy and recognize that this is a novel risk factor for stroke and dementia. And finally, we will examine left atrial function and appreciate that it is an important and key biomarker for stroke and dementia prediction. So the heart and the brain are closely connected. Risk factors that increase the risk of heart disease, such as high blood pressure and diabetes, are in and of themselves risk factors for stroke and dementia. Moreover, established cardiovascular disease are also risk factors for stroke and dementia, and these include coronary artery disease, which means the buildup of cholesterol plaques in the heart arteries, and also heart failure when the heart is too weak or stiff to pump effectively. Now, in recent years, we also know that heart rhythm abnormalities or arrhythmias are also risk factors for stroke and dementia. And this brings us to atrial fibrillation, which is the most common and sustained heart rhythm abnormality that affects middle-aged and older adults. Atrial fibrillation is characterized by a rapid and irregular heartbeat. And patients can have symptoms such as palpitations or a racing heartbeat sensation. For the past 4 decades, we have known that atrial fibrillation is associated with a 5-fold increased risk of ischemic stroke. And this relationship has profoundly influenced the practice of medicine and cardiology because doctors prescribe anticoagulants or blood thinners to prevent blood clots and stroke in people with atrial fibrillation. It is widely believed that underpinning this relationship between atrial fibrillation or AFib and stroke is the Virchow's triad, comprising stasis, which means abnormal blood flow, hypercoagulability, which means an increased tendency for blood clot formation, and finally, endothelial dysfunction, which is abnormal function of the blood vessel lining. So these three factors can conspire to increase blood clot formation and then which can lead to a stroke. So here is one way to understand it, or the conceptual model. The irregular rhythm of AFib increases blood clot formation in the heart chambers. These blood clots go to the brain to cause stroke. Over time, there is brain loss or brain atrophy leading to dementia. Now, AFib can also lead to cognitive impairment independent of overt or clinical stroke. So shown here is a meta-analysis that was published in 2013, and we can see that the presence of atrial fibrillation increases the odds or the risk of cognitive impairment by more than 30%. However, the studies that were included in this meta-analysis had several limitations. For example, many were cross-sectional, which means they were assessed only at one point in time. And even those with longitudinal follow-up, the follow-up time was relatively short, about 5 or 10 years. And importantly, did not take into account an Achilles heel in such observational studies, namely attrition bias, which means that the results of these studies could be biased because of the loss to follow-up of participants. So to address limitations of studies at that time, we published this paper in 2018 in the Journal of American Heart Association. And indeed, in this paper, we showed that atrial fibrillation over a long follow-up time of more than 2 decades is associated with a higher risk of dementia and greater cognitive decline. And this paper was based on the ERIC study, or the Atherosclerosis Risk in Community study. So ERIC was a multi-center prospective biracial community-based cohort study, which enrolled close to 16,000 middle-aged individuals at the end of the 1980s from 4 USA communities. Since the baseline exam, many study exams have been completed. The last was in 2024. And in between study exams, annual telephone interviews were conducted to assess the health outcomes and status of participants. So in this paper, we focus on 3 time points, visit 2, 4, and 5, because at these 3 time points, ECGs were performed to assess atrial fibrillation, and a battery of neurocognitive tests were done to assess brain function. And that enabled us to link AFib to change in cognitive function over time and dementia. And we found that in analysis that was unweighted, as well as weighted to take into account attrition bias, atrial fibrillation was associated with a greater decline in global cognitive function, as well as executive function as measured by the digit symbol substitution test. Moreover, atrial fibrillation was associated with close to 25% higher risk of dementia. And this association is independent of dementia risk factors, including overt clinical stroke. Yet, many experts in the field are asking this tantalizing question. Is AFib truly a risk factor or merely a risk marker for stroke and dementia? What is the basis for this skepticism? Well, there are many reasons for this skepticism. And one important reason is that in recent years, cumulative research has emerged to indicate that the underlying abnormal left upper chamber or the left atrium or atrial myopathy can easily explain the association of AFib with stroke and dementia. In other words, the association of AFib with stroke and dementia that we've known for quite a while may be partially confounded by underlying abnormal left atrium. So let us go on to examine this atrial myopathy. So what is this? Now, first and foremost, this is a relatively new clinical entity that we helped to coin the term. In the literature, it is also known by other names such as atrial cardiopathy. Shown here is a schematic diagram of the heart with the two upper chambers, and these are the atria. The lower chambers are the ventricles. And these upper chambers are abnormal. They are very large. So atrial myopathy is characterized by alteration in the size of the left upper chamber, but more importantly, impairment in the function of the left upper chamber. And we will go into this in detail shortly. Atrial myopathy also includes perturbation in electrical activation within the upper chambers. And furthermore, encompasses perturbations in molecular pathways such as endothelial function, coagulation, inflammation, and oxidative stress. So we now have a new conceptual model to understand the relationship between AFib, atrial myopathy, blood clots in the heart chambers, stroke, and dementia. So we have known for a while that the irregular rhythm of AFib increases blood clot formation in the upper chambers, leading to stroke and then dementia. But now we understand that atrial myopathy in and of itself, independent of and in the absence of AFib, can also lead to this cascade of events because impairment of the function of the left atrium disrupts blood flow in the left atrium, and that can set up the nidus for blood clot formation, leading to brain infarcts, stroke, brain loss, and then dementia. So how do we know that this is actually true? Well, let us then examine left atrial function. So several years ago, we were fortunate to receive this grant from the NIH to conduct this study. With this grant, we were able to measure left atrial function from heart ultrasounds or echocardiograms of close to 6,000 participants in the ERIC study. So after completing the measurement of left atrial function from close to 6,000 heart ultrasounds, we were then able to analyze the data, perform different analyses, and publish several papers to support our hypotheses. So let's look at some of these. Starting with this paper that was published in the Annals of Internal Medicine in 2023. And this paper was led by two previous mentees, Dr. Ankit Maheshwari, who is an assistant professor at Penn State, and Dr. Faye Norby, who is an assistant professor at the University of Minnesota. And in this paper, Ankit and Faye showed that a dysfunctional left atrium is associated with higher risk of stroke in people without AFib and prior stroke. Let us look at the results in greater detail, and I'll walk you through this. So this slide shows the three function measures of the left atrium: reservoir, conduit, and contractile. And this figure shows the relationship of these function measures to the incidence of stroke on the y-axis. The function measures are categorized into quintiles, in other words, into 5 groups. The highest quintile is the best quintile, and that serves as a reference. The lowest quintile is the worst group. So for both reservoir and conduit function, as compared with the best group or the reference group, participants in the lowest quintile had significantly higher incidence of ischemic stroke. We did not observe any relationship between contractile function and left atrial size with stroke. Moreover, when we added left atrial function to a prediction model that we commonly use to predict risk of stroke in people with AFib, we were able to improve our prediction ability. In other words, we can now more accurately classify people who are at high risk as high risk, or people who are at low risk as low risk. And specifically in this case, our improved ability to classify is driven by correct classification of high-risk individuals. Let us now look at dementia. So this paper was published in JAMA in 2022, led by a previous postdoctoral fellow, Dr. Wendy Wang, who is now an assistant professor at UT Southwestern. And in this paper, Wendy showed that several measures of left atrial function were associated with higher risk of dementia independent of AFib. And again, we did not observe any association between left atrial size and dementia. Let us dive into the details. Again, there are 3 different measures of left atrial function. Each measure we categorize into quintiles or 5 groups. The highest quintile serves as a reference. For all 3 strain measures, as compared with the best group, the lowest group was significantly associated with a higher risk of dementia, and the strongest association was with reservoir strain, when the risk was almost elevated twofold. Let's look at the results again in the visual format in this figure. On the horizontal axis, that's the reservoir function, and on the vertical axis, the incidence of dementia. And here we can clearly see as the reservoir function decreases, the incidence of dementia increases. Importantly, the relationship is not a straight line. It is not linear. So that gave us the opportunity to define a cutoff to classify what is normal and what's abnormal left atrial function. So in this paper that was published in JAMA, we show evidence that a left atrial strain of less than 27% might be the cutoff. And then finally, in this paper that was published in JACC Advances in 2023 and led by a cardiac imaging fellow, Dr. Michael Zhang, who will be studying as an assistant professor this July at the University of Minnesota. And in this paper, Dr. Zhang re-evaluated the association of AFib with stroke and dementia that we have known for such a long time. But this time, and for the first time, taking into account the underlying left atrial function. And these are the results. So no surprise, AFib is associated with a higher risk of stroke, higher risk of dementia. But when we adjusted or took into account underlying left atrial function, these point estimates of 63% were substantially reduced to 33% and no longer statistically significant. Similarly, the association with dementia with a point estimate of 38% was substantially reduced to 15% when we adjusted for left atrial reservoir strain and no longer statistically significant. So these results indicate that the association between AFib and stroke and dementia that we have known for a while might be partially explained by the underlying atrial myopathy. So, in summary, here are some take-home points. Other than AFib, we now recognize a new clinical entity known as atrial myopathy, characterized by abnormal left atrial function, as a novel risk factor for stroke and dementia, independence, and in the absence of AFib. Therefore, preventing atrial myopathy and its progression may be a key strategy to prevent stroke and dementia. And specifically, perhaps it is time to consider a trial that would test the role of blood thinners or anticoagulants to prevent stroke or dementia due to atrial myopathy in the absence of AFib. So I would like to thank past and current members of my lab, my collaborators at the University of Minnesota, my extensive network of collaborators in other studies, ERIC staff and participants, and also the NIH for supporting my research. And thank you, and I look forward to the discussion later this evening. Thank you.
Thank you. Thank you, Dr. Chen. I'd like to introduce Dr. Thenapin. Dr. Thenapin is a professor of medicine in the cardiovascular division at the University of Minnesota Medical School. He is a clinical research scholar whose research is focused on finding new ways to help the heart stay strong when it is under stress from lung-related illnesses. His goal is to develop better treatments that can improve patients' heart and quality of life. Dr. Thenepin, could you discuss the connection between gut bacteria and heart disease?
Thank you, Forum, for this opportunity and the kind introduction. So thank you, everyone, for attending despite a beautiful weather outside. I'll try to make this presentation useful for you. Consistent with the topic today, my goal is to discuss our research and work on the link between heart health and gut health. And let me share my screen and then get started. Okay. Let me just make sure I'm doing it. Okay, here's good. So here is these are our disclosures. So we do get research funding from several pharmaceutical companies for clinical trials, but nothing is relevant to the stock. And these are the pharmaceutical companies from which we receive funding. So the learning objectives of the next 20 minutes is to understand the role of gut microbiome or gut bacteria in the development of a heart-lung condition called pulmonary arterial hypertension. So pulmonary arterial hypertension is high pressure in your lung arteries. So like your regular blood pressure, you have blood vessels in your lungs, and the pressure in those arteries can be high. And that condition is called pulmonary arterial hypertension. And when the pressure in your lung arteries are high, the right side of the heart has to pump against this high pressure. So it works harder, and over time, then it becomes tired and it fails. And we and others are now understanding that the gut microbiome, or the bacteria or the virus and the fungi in your gut, could be playing a role in this disease. And if we can modulate or restore that bacteria or fungi or the virus in your gut, we can actually make this disease better. So if you have a good gut health, you probably can have a better heart health. That's the overarching hypothesis. So why do we think this? So in this disease of high pressure in the lungs called pulmonary arterial hypertension, inflammation is a critical factor. Okay, how do we know that? When we take these arteries from patients who die of disease and do an autopsy, we see inflammation in the blood vessels. Then when we take their blood and measure different measures of inflammatory markers, these are called interleukins. These are basically proteins that is secreted by your immune cells into the blood if the immune system is revved up. And what we understand is if the inflammatory markers, these interleukins, are high, those patients do worse. Similarly, if you go to a preclinical experiment on a rat model, and if you overexpress or if you give more of these inflammatory markers, those rats or mouse develop pulmonary hypertension. So these critical evidences in the last several years suggest that inflammation plays a role. Okay. Now, what is this gut microbiome and what is gut dysbiosis? All of us in our gut, we have trillions of microorganisms. These include bacteria, fungi, virus, and sometimes parasites. And all of these organisms have genes like us. The collective genome of all these organisms is called the gut microbiome. And these organisms are called the gut microbiota. If these bacteria or if this gut microbiota composition and function is altered compared to a healthy person, that's called dysbiosis, meaning it's not similar to a healthy person. Now, this little cartoon to your right-hand side shows the different classification systems of this gut bacteria. For example, there are different levels, it's life first, and under life, there are different domains. Under domains, we have different kingdoms. Then under the kingdom, we have different phyla. So it's basically a classification tree of the different bacteria. And each individual bacteria will be at the species level. Okay. And what we are learning is when you have an abnormal gut microbiota, it's called the dysbiosis, what it does is it increases gut permeability. What do we mean by permeability? The gut is intact. It doesn't allow any bacteria or fungi or virus inside the gut to enter into the body, into the blood. But if you have an abnormal gut bacteria, this gut integrity gets abnormal. The gut becomes leaky. So the stuff in the gut, the bacteria can enter into the system. Okay, number one. That when this bacteria enters into the blood, that revs up the immune system and causes inflammation. That's one way it can cause inflammation. The second way by which this abnormal gut bacteria causes inflammation is by secreting certain metabolites. So when we have these bacteria metabolizes the food we eat. And depending on the type of bacteria we have and the type of food we eat, you can have either good metabolites or bad metabolites. If there is decrease in this good metabolites and there's an increase in bad metabolite, then these metabolites go into the blood and activates the immune system or revs up the immune system and causes inflammation. So a healthy gut keeps your immune system under control. On the other hand, if you have an abnormal gut, it then causes inflammation. There is evidence that this gut permeability or the gut is leaky in animals with this disease. Also, okay, I'm just going to skip all this. What we decided a couple of years ago is, okay, why don't we study these in patients with pulmonary arterial hypertension, this high pressure, and compare it to healthy people and see whether there is any difference. So based on a funding from University of Minnesota, we took 75 patients in our clinic. We then were able to get 39 healthy volunteers. And then we also got 15 healthy people from the family who are living with the patient, and then compared their gut bacteria. And this graph, this alpha diversity, means if you have a diverse, high diversity, that means you have a healthy bacteria. And what we found was patients with PAH, to your left-hand side, you can see, the shown in red color, they have less diversity. They have less, they don't have diverse bacteria. They just have only one or two types of bacteria, and they just don't have a variety. And okay. Then we went in and compared at a very individual level what bacteria they have. And what we found was, compared to healthy people as well as family control, these patients with pulmonary arterial hypertension have increase in this particular group of bacteria called Proteobacter and Bacteroidetes. But they have less of this other group of bacteria called Acinetobacter and Firmicutes. Acinetobacter and Firmicutes are healthy bacteria, whereas Bacteroidetes and Proteobacter are bad bacteria, for lack of better words. They cause us inflammation. So, for example, if you go to a grocery store, get a probiotic, what it has is lactobacillus, which is a Firmicutes. Okay. So what we saw was in patients with pulmonary hypertension, there's less of those good bacteria and more of these bad bacteria. And we looked at much higher resolution, and we saw a similar pattern. Red means these are unhealthy bacteria. Gray means these are healthy bacteria. And we saw that the unhealthy bacteria are much higher in patients with this pulmonary hypertension, whereas healthy bacteria are rich in healthy people. Then we went and looked at the functionality of the bacteria, whether these bacteria are really like making abnormal metabolites by looking at their genes, and we saw a similar pattern. And I'm going to skip this just for lack of time. What we then said was, okay, we are seeing that these patients with pulmonary hypertension have an abnormal gut microbiome, an unhealthy pattern, but does it relate to the severity of the disease? And what you can see in the graph here on the x-axis is like different measures of the severity of the pulmonary hypertension. On the y-axis is the measure of diversity. So if you're really have a healthy gut, you should have a diverse microbiome. And what we saw was, as the severity of the pulmonary hypertension gets worse, we saw a decrease in the diversity. of the bacteria. We did not see any relationship between the right-sided heart function and the diversity, but we mainly saw a relationship between the severity of the pulmonary hypertension and the diversity. Okay. So then the next slide is, okay, so compared to healthy people, PAH patients have an abnormal gut microbiome. They are inflammatory in nature. They have less healthy bacteria. Then what we thought was, okay, within PAH patients who have this disease, we wanted to say, is there a difference in the bacteria between those who really do well and respond to treatment versus who are really not doing well and not responding to treatment? So progressive means they are not responding to treatment and they're having a progressive disease. Stable means they are responding to current therapy. What we found was, as you can see, these two, this graph on your left hand side is called a principal component analysis. If they are similar, there will be overlap, but if they are not similar, there won't be any overlap. And you can clearly see the progressive, which is shown in pink, is not overlapping with patients who are unstable. So that means their microbiome is completely different. And these are the middle panel shows what are all the bacteria that are different. And again, we saw more inflammatory, unhealthy bacteria in unstable patients. And patients who have such kind of unstable bacteria lived much less or shorter when compared to people who have a stable bacteria, which is shown on the graph on the right-hand side. So to summarize our work so far, what we are seeing is antibiotics we take, pollution in the environment, the type of diet we eat can alter the bacteria in our gut. And if for some reason we are exposed to antibiotics, we are eating a very low fiber diet, and we are eating saturated animal-derived diet or high cholesterol-rich diet, that can make the bacteria into an unhealthy one called gut dysbiosis. When you have an unhealthy bacteria, these bacteria then makes your gut leaky and also releases these abnormal microbial products. These products then enter into the blood and stimulates the immune cells. These are called the macrophages or lymphocytes, and causes inflammation. This inflammation in the blood, when it circulates into the lungs, makes the lung arteries proliferate or grow and become much thicker, that then leads to high pressure in the lungs, called pulmonary hypertension. One way to treat the disease then is, okay, in addition to standard of care, if we can change the unhealthy gut microbiome into a healthy microbiome, can we reverse this? For example, if you have a healthy gut bacteria, then your gut won't be leaky. You won't be secreting these abnormal bacterial metabolites. So that means you won't be revving up your immune system, so you can decrease inflammation. One way to do that is called a microbiota transplant. So this is an emerging concept. It's currently approved by the FDA to treat some conditions that affects the colon, but it's also now being studied to treat heart disease like pulmonary arterial hypertension. So healthy donors go and donate their stool samples. And at the university, we are fortunate to have something called a microbiota therapeutics program. So they developed this product for us. So the healthy donors go there, donate their stool samples. The stool samples, the stool materials are all filtered, and just the microbiota alone is taken. And that is then made into a freeze-dried capsule. These capsules are then given to patients. So it's like a probiotic capsule, but it's rich in several trillions of bacteria and fungi and virus. And we give it to the patient and see whether this could restore their gut health to healthy one. So we are fortunate enough to receive funding to study this in patients with PAH. This is an early safety and feasibility trial. So we just took 11 patients who were willing to see whether this would be effective for them. And we did this microbiota transplant. Basically, this is the capsule they will take. They will take 2 capsules for 7 days. and then we monitor them for 6 months. And so far, this is the characteristic of the patients we studied. And what we are seeing is it's definitely feasible. Every patient can take this and complete all the protocol of the study. It's very safe. We are not seeing any serious side effects related to this, and very minimal side effects. Those are related to like GI related side effects. Mainly, like some patients had diarrhea, some nausea, and tenesmus, but no serious side effects. When we give the microbiota transplant, not all the healthy bacteria we give are taken by the recipients because they have their own bacteria which can fight against this. And what we are seeing is, like, on an average, 18 to 20% of the healthy bacteria we are giving are taken by these patients. We would like this to be better, so we are altering our protocol to make this even better. And that's where we are right now. And what we saw was and here, this is at baseline, how much they're walking, which is if you have a pulmonary arterial hypertension, it reduces your exercise capacity and it affects your quality of life. So compared to baseline, at 6 months after having the therapy, there is an increase in their 6-minute walk distance. That means they're able to walk more. We don't do statistical testing because this is an early trial, but so we are seeing a signal. We can't say for sure, but definitely we are seeing a signal. Then emphasis then is a quality of life score we do to see how good the patients feel. Lower score is better. So after treatment, what we saw was there is a decrease in the score, which means that patients are feeling better after treatment. This is an open label trial. It's not placebo controlled, so it's too early to say for sure this is a true effect, but we are seeing some positive signals, which encourages us to go and study this as the next step. So with that, now we are going to the next step. We are going to the placebo-controlled trial to study this in a larger number of patients with a higher dose of the product, but also a placebo group to see, hey, what we are seeing, is it indeed true? Are we making the bacteria healthy in these patients? Or are we decreasing the inflammation? Are we benefiting PAH by improving their 6-minute walk test and quality of life? So in conclusion, what we found with others in the field is this heart disease called pulmonary arterial hypertension is related to an abnormal gut microbiome. And human studies and animal studies suggest that there is a strong relationship. And by replacing the unhealthy bacteria with healthy bacteria through microbiota transplant, it's a potential future treatment option. And it's safe and feasible, in which we just need to optimize the dose for future studies. I'll stop there. Thank you again for the opportunity.
Thank you, Dr. Thanappan. Now it's my pleasure to introduce Dr. Suma Kennedy. Dr. Kennedy is a professor of medicine who specializes in cardio-oncology, cardiac imaging, and women's health. She directs the cardio-oncology clinic at the University of Minnesota, where patient-centered cardiovascular is provided to patients with active cancer and to those who are cancer survivors. Dr. Kennedy's research interests include prevention and early diagnosis of cardiac toxicity caused by chemotherapy and radiation therapy. Dr. Kennedy, could you discuss how cancer and heart disease are related?
Thank you, Forum, for the kind introduction, and thank you for inviting me for the mini-series. And thank you to all the participants who have registered. I'll be delighted to spend the next 15-20 minutes to give you a clinical overview on the intersection of cancer and heart disease. So I'm a professor of medicine here in the cardiovascular division, and I direct the cardio-oncology program. Next slide, please. No relevant financial disclosure other than the fact that I have a research grant to evaluate some early signs of cardiac dysfunction in patients undergoing chemotherapy. Next slide, please. So I will spend here's my outline of my talk. We'll spend some time reviewing how interconnected heart disease and cancer is. When we think about heart disease and cancer, we always think about cancer therapies increasing the risk of heart disease. I will show you some data, which is compelling, but epidemiological data showing heart disease can also increase the risk of cancer, and then explore some shared risk factors and mechanisms that could explain this bidirectional relationship of heart disease and cancer. Next slide, please. So clearly, I think we're all familiar that heart disease and cancer are the two largest public health burden in terms of age-adjusted death rate, leading causes of death in the United States. So making an impact and improving outcomes of both heart disease and cancer would have a substantial impact from a public health domain. Next slide. So when we look at cancer survivors and look at the cause of death amongst cancer survivors, heart disease essentially encompasses about 40% of the non-cancer death. And this is more relevant in prostate cancer and breast cancer patients because of all the advances we have had in prostate and breast cancer patients. There are some cancers, such as lung, pancreas, and brain tumors, that patients are more likely to die of their cancer. But specifically in some of these patients, in prostate and breast cancer patients, the outcomes are really good when it comes to cancer specific survival. And we have to be really careful about cardiac surveillance in such patients. So this essentially underscores the need for continued cardiac surveillance. Next slide, please. So we're all familiar that cancer survivors, the number of cancer survivors in the United States is continuing to grow, which is great. And this is owing to several advances in diagnostic tools, in therapeutics that are available, and also in survival strategies that we employ. And I'm sure a lot of us are familiar amongst our friends and families who have been cancer survivors, and it's wonderful that they continue to grow. Next slide, please. So historically, heart disease and cancer have been viewed as two distinct entities, but this perspective is changing. They're increasingly being recognized as being fundamentally interconnected. They share several risk factors and mechanisms. And let's have a look at this. Let's do a deep dive into this. Next slide, please. Now, it's not uncommon that we find patients with heart disease. If you may kindly click on, I guess, the videos, yeah. Another click, so the video plays. Anyway, I'm sorry, the top panels are not, the videos are not playing. Yep. So it's not uncommon that we find patients with cardiomyopathy, which means weakening of the heart muscle, or colon cancer patients with significant coronary atherosclerosis or calcification in the coronary arteries, as demonstrated in panel B, needing to have their heart disease addressed even before embarking on cancer therapies. We often also encounter patients with irregular heart rhythm and atrial fibrillation, and we heard Dr. Lin-Yi Chen very eloquently talk about atrial fibrillation and the associated risks with it. So these entities can occur even before patients get cancer therapies, and this is and clearly this requires very careful baseline surveillance of cancer patients before they embark on cancer therapies. Next slide, please. So our work and that of others have explored the overlap of cardiovascular disease and cancer. So when we look at risk factors such as obesity, diabetes, hypertension, tobacco, and dietary issues, and then physical inactivity, we always think about heart disease. So our work in a few years back actually was one of the first few papers that actually looked at the intersection between heart disease and cancer. So here we have a graph of the modifiable cardiac risk factors with their estimated cancer risk. So as you can see, tobacco smoking has a very strong association with cancer, and it's also a very common risk factor when we encounter coronary artery disease in patients. Next slide, please. So let's look at some of the cancer therapies that can can increase the risk of heart disease. Now, this slide is a busy slide and essentially gives you, in a nutshell, of the myriad of cardiovascular problems that can occur after cancer therapy. And essentially, the takeaway from this should be that the importance of baseline assessment, surveillance, both during and after treatment. So let's try to look at this in detail. So there are several chemotherapeutic agents, anthracycline, which is a mainstay chemotherapy for several cancers used in breast cancer, lymphoma, leukemia, etc. Agents such as that are used for multiple myeloma therapy, protease inhibitors, breast cancer therapies, HER2 targeted therapies, cyclophosphamide, all of these, and some of the other tyrosine kinase inhibitors that interfere with essential protein synthesis, but are meant to be targeted therapies towards cancer cells. And VEGF inhibitors or vascular endothelial growth factor inhibitors, all of these can lead to cardiomyocyte damage and weakening of the heart muscle and thereby heart failure. Some of these tyrosine kinase inhibitors can also cause hypertension, and testicular cancer patients who receive cisplatin, colorectal cancer patients who receive 5-FU, all of these agents can cause ischemic heart disease or problems with blood flow to the heart muscle. And radiation therapy can stiffen the heart, can lead to pericardial disease, which is the lining of the heart muscle, which is the lining of the heart, valvular heart disease, typically affecting the aortic valve and the mitral valves on the left side of the heart, and cause fibrosis and narrowing of the heart muscles. There are certain other medications, or I should say chemotherapeutic agents, that are used to address specific type of cancers that could also lead to arrhythmias and irregular heart rhythms, such as atrial fibrillation. Next slide. So from our early knowledge of radiation therapy causing heart disease, we've come a long ways. So this was a study that was published in 2013 looking at women who received breast cancer, radiation for breast cancer between 1958 and 2001 in Sweden and Denmark. So basically what this study brought to light was that radiation therapy, higher the dose of radiation therapy, there's a higher risk of death from ischemic heart disease. And when when risk factors get added, so if patients had hypertension and diabetes, that creates an additive problem. So radiation in and of itself, and along with risk factors, can impose a high cumulative risk of of death from ischemic heart disease and also coronary events in these patients. So this is to be taken with a grain of salt because the current day radiation therapy is far more precise and is more targeted. And there's a lot of 3D CT planning that is involved in radiation therapy designed to exclude the cardiac structures so that the radiation therapy is focused towards the tumor per se. Next slide, please. So we have seen studies from prior radiation therapy to Hodgkin's patients with an increased risk of cardiovascular disease. And when chemo, I'm sorry, I'm not able to demonstrate to you with my mouse or a pointer because I don't have control over my slides here. But what I wanted to say, the orange line on top, which has the highest risk or the highest cumulative incidence of cardiovascular disease is folks who received mediastinal radiation along with anthracycline, and the bottom line on the graph in comparison to patients who had no radiation therapy and no anthracycline. These days, we've moved away from from radiation therapy, mantle radiation therapy, to Hodgkin's lymphoma, and they're most oftentimes treated with just chemotherapy alone. Next slide, please. So there are more and more reports of these heart failure in breast cancer patients, left-sided radiation increasing the risk of coronary artery disease in breast cancer patients. And all of this have sort of brought to light the importance of continued surveillance into survivorship. Next slide, please. And in terms of prostate cancer therapy, androgen deprivation therapy is the cornerstone of treatment. It reduces androgen levels and prevents prostate cancer cells from growing. However, it's linked to heart disease as a growing concern. And ADT is thought to mediate through hypogonadism, alters the body composition, the lipids, and also impairs glycemic control, thereby increases the risk of diabetes and a fairly high 75% risk of metabolic syndrome. So this is actually one of the lesser studied problems, I would say, in cardio-oncology, where most of the focus has been in breast cancer patients. Next slide, please. So let's look at some of the epidemiology data looking at heart disease causing incident cancer. So the reverse paradigm. So most of the data, as I said, is not from clinical trials, but from retrospective look, either by community-based case-controlled studies, or some prospective studies. But it's kind of intriguing in that patients with heart failure having a higher risk of incident cancer. So this was initially when this was published, it was sort of unclear whether this would, could be replicated in other studies, or if this was just clearly these are association and not causation at this point. So it was unclear how to interpret these. But from this data here, we have about 60 to 70% increase risk of cancer in patients with heart failure. To the right panel, the heart failure in a homogeneous group of patients after myocardial infarction or after heart attack, having a 70% increased risk of cancer. The average follow-up on all of these are in the order of they extend up to 10 years. But some of these, as you can see on the right side, the incident MI, years after incident MI was only 5 years, and you can already appreciate that the divergence of the curves in this, portending a higher risk of heart failure in these post-MI patients. Next slide, please. Here's another study a Danish study, again, looking at a heart failure cohort where there's a 24% increased risk of cancer, except prostate cancer in this cohort of group patients or participants, I should say. Then again, the green lines here is heart failure in participants over 70 years of age, and the dotted green is the background population of 70, so a higher risk or a higher incidence of cancer in participants with heart failure. Similarly, this is an age stratified data that's presented in the form of the graph with heart failure in less than 60 in the blue line, and heart failure in participants of 50 to 69 and over 70 here. So age itself increases the risk of heart failure. Then in addition, increases the risk of cancer. And in addition, when there's superimposed heart failure, that further increases the risk. Next slide. So the data is not all clear and unidirectional, I would say. The physician health study, again, showed no association between heart failure and incident cancer. Physician health study, as you might be aware, included about 28,000 physicians with mail-in surveys, essentially, and about 1,400 of them developed heart failure, and about 7,000 of them had cancer. And the median follow-up was about 20 years. And as you can see, there was no, on the left-hand panel, there's no association between heart failure and site-specific cancer incidence or mortality. On the other hand, the Women's Health Initiative study, which is a large cohort of postmenopausal women, heart failure was associated with increased risk of cancer. The association was strongest for lung cancer and colorectal cancer, and was most pronounced for heart failure with preserved ejection fraction. What that really means is the heart function, the pump is normal, but the heart doesn't relax. And thereby results in clinical heart failure in these patients. A point to be made is there was no association in this Women's Health Initiative with breast cancer. Next slide, please. Now, we've examined the association of heart failure with cancer. Let's look at the data with coronary artery disease and cancer. Here's a population-based study using IBM market scan claims data of 27 million participants. Now, in this study, cardiovascular disease was associated with a higher risk of cancer. So what this really means is in participants who had atherosclerotic coronary artery disease specifically, at a higher risk of cancer when they were followed up. The median follow-up in this study was as little as 3 years. So there is a signal that you can see about 20% increased risk of participants with atherosclerotic disease versus no atherosclerotic disease, with the higher risk of cancer developing in these participants. Next slide, please. So let's next examine some shared risk factors and shared mechanism that could explain the bidirectional relationship. As biological mechanisms continue to be elucidated, it is very important to remember, aggressive risk factor modification should be continued for not only secondary, to prevent a second heart attack but also potentially to prevent a primary cancer from developing. As I mentioned, amongst cancer survivors, heart disease is a leading cause of non-cancer related mortality. From Eric's study, we know that individuals who maintain good cardiovascular health have a lower risk of incident cancer. There was an interesting clinical trial using an anti-inflammatory agent called canakinumab that demonstrated very promising effects in reducing cardiovascular events. And in this study, as a secondary endpoint, also reduced lung cancer incidence. But follow-up trials using the same drug really did not show any improvement in disease-free survival in non-small cell lung cancer patients. So perhaps it helps with preventing incidence, but when patients already have cancer, it has no impact, essentially. But what this really highlights or supports is the inflammatory intersection between heart failure and cancer. Next slide. Now, the shared mechanisms underlying both cancer and cardiovascular disease include chronic inflammation, oxidative stress. We heard a little bit about microbial dysbiosis, metabolic dysregulation. Another sort of emerging theme is this clonal hematopoiesis of indeterminate potential, which is not a cancerous condition, but has a risk for transforming into leukemia. But this is a clone of type of white cells that develop where there's also increased inflammation, which may be a mediator for both cardiovascular disease and cancer. Hormonal effects, and cell senescence, all of these are some of the shared mechanisms that are being widely studied. And essentially, targeting chronic inflammation could be an effective therapeutic strategy to mitigate not only cardiovascular disease, but also to prevent incident cancer, as I mentioned. So in conclusion, I hope I've convinced you that heart disease and cancer have a bidirectional relationship with shared mechanisms and risk factors. Patients with cancer are at increased, sorry, next slide. I forgot to, one after this. Yeah. Patients with cancer are at increased risk for heart disease as a direct effect of cancer itself or from cancer therapeutics, as we examined a few examples here. Epidemiology data suggests that patients with heart disease are also at increased risk for cancer. And there are shared pathophysiological pathways, including oxidative stress, neurohormonal activation, and chronic inflammation, which may explain this bidirectional association. But more importantly, I think aggressive risk factor modification for heart disease prevention could also potentially prevent cancer. So prevention, healthy eating habits, eat less, move more, and eat wise, I think would be the mantra for both cardiovascular prevention and also for cancer prevention. Next. And I will end my talk with that, and I'm happy to take any questions.
Thank you, Dr. Kennedy, and thank you to all the panelists. Now we'll move on to the questions submitted by our attendees. As a reminder, you could submit your questions to our panelists using the Q&A box which can be found by clicking the Q&A button at the bottom of your Zoom screen. So I'll start with Linyi. Is there any research suggesting that lifestyle changes or certain medications used to manage atrial fibrillation might also help protect the memory or brain health?
Thank you for that great question, Forum. Yes, actually, there's quite a bit of research that is showing that lifestyle modification, which is helpful for atrial fibrillation, and by that I mean increasing physical activity and leisure time physical activity, dietary modification, as well as weight loss and maintaining a healthy weight. All of these have salutary benefits for atrial fibrillation, and they can also reduce the risk of dementia and stroke. Now, medications as well, and specifically medications to control blood pressure. These medications, by lowering blood pressure, can reduce the risk of atrial fibrillation, and then at the same time, can also reduce the risk of stroke and dementia. So there is definitely evidence in the literature that medications as well as lifestyle changes can be beneficial for both the heart and the brain. Thank you.
Thank you. And then I'd like to ask a question, Dr. Thenepin. In your looking at the microbiota in pulmonary hypertension, are there specific foods or probiotics that have been shown to improve heart health by supporting a healthier microbiome? And then what do you think people could do that could also help to keep their healthy microbiota thriving?
No, thank you for that question. So to begin with, what are all, to answer this question, one way is to understand first what are all the factors that affects our gut microbiome. I think all of us are born with a certain amount of gut microbiome, and that evolves over our childhood. But then once we become an adult, it's predominantly stable, but certain factors changes. Antibiotics are the ones which are we call the antibiotic as a time bomb. It's like putting a time bomb in this green lush forest, which destroys everything. So recurrent unnecessary use of antibiotics is unhealthy. Diet plays an important role in how healthy bacteria you have in your gut. And what we know is plant-based diet, and especially fiber-rich diet, is very important to have a healthy bacteria. On the other hand, if you have more saturated fat and red meat, that increases the chances of you having an abnormal inflammatory bacteria. Genetics plays some role in the type of bacteria we have. Exercise also have shown to have an effect on the bacteria. So having as the American Heart Association would say, the big eights, having out of the big eights, diet and exercise are the two ones. So having a healthy diet and having good exercise program routine, you have a healthy bacteria. Now, so the second question is, can probiotics be beneficial? Probiotics are definitely beneficial, but are they enough to treat a heart disease like PAH is the question. And when our understanding right now is it's not enough. It's helpful, but it's not enough. Because why do I say that? Probiotic has 4 healthy bacteria, whereas the gut microbiome has 4 trillion organisms. There are several bacteria, there are several fungi, and there are several parasites. A colleague of mine used this example. To have a healthy city or a town, you need a plumber, you need a police officer, you need a judge, you need a doctor. So you just don't want to have one of just doctors alone, or it's like everybody need to play and work together. So you need that ecosystem. So that's why probiotic alone is not enough. Having a good healthy gut bacteria has all these different players that can make your gut healthy. So I'll stop there.
Thank you for that response. I'd like to ask you a question, Suma. We hear a lot about how cancer treatments can affect the heart, but are there ways that people can reduce the risk of both cancer and cardiovascular disease?
Yes, in terms of, as I mentioned, participants in the ERIC study who had the best cardiovascular profile also had the least incidence of cancer. So which is a testament to good cardiovascular health as preventing cancer. Obviously, given the many shared risk factors, avoiding smoking, eating healthy, avoiding red meat, obesity has been linked with endometrial cancer, breast cancer, maintaining a good weight. And there's more and more data coming out about physical activity as also improving these chronic conditions. So,
Thank you. And a question to you, Lin Yi. How can atrial myopathy be diagnosed, and what tests would you recommend for patients who may have atrial fibrillation to be able to assess their risk of dementia?
Okay, great question. And thank you for that question, Faron. So atrial myopathy can be diagnosed using heart imaging tests. And the two most common ones would be a heart ultrasound, or commonly known as an echocardiogram, and also an MRI study that's dedicated for the heart. So that's known as a cardiac MRI. These two imaging tests enable us to assess the function of the left atrium and hence diagnose atrial myopathy. Additionally, we can also use the standard electrocardiogram or the ECG because there's certain parameters or certain features, namely the P wave, if they're abnormal, that can give us an indication that there's atrial myopathy. Some blood test markers like BNP, if they're elevated, that can also indicate atrial myopathy. Now, regarding the second question, in people with atrial fibrillation, how can we diagnose underlying atrial myopathy? It would be the same test as well. So if somebody has atrial fibrillation, very commonly they get an echocardiogram done. And from the echocardiographic images, we will be able to ascertain or diagnose the atrial myopathy based on the left atrial function. And what to assess the risk of dementia. So as I explained in the paper that I showed during the presentation, if people have lower left atrial function below a certain cutoff, in that paper we had a cutoff of 27%. If the strain is less than 27%, then there can be an elevated risk of dementia. Thank you.
Thank you for that question. I'd like to ask Dr. Thenip a question. All three of you have actually discussed, and everyone's welcome to answer, the role of inflammation in the development of atrial fibrillation, pulmonary hypertension, as well as cancer-related cardiotoxicity. And then specifically to you, Dr. Thenipin, does the microbiome transplant that you've assessed in patients with pulmonary hypertension, does that actually replace the unhealthy gut bacteria with healthy bacteria? Does it add to the pool of existing bacteria? And how can others also try to reduce their inflammation in this way?
Yeah, perfect. Thank you so I'll probably answer first aspect, inflammation. I'm just going to focus on pulmonary hypertension. I'll have Dr. Chen and Konetti talk about cancer. So there's so much evidence now suggesting that inflammation plays a critical role in this type of heart disease called pulmonary arterial hypertension. And we initially, 20 years ago, thought that, hey, this is as a cause of the disease, and it's actually not, like it's a result of the disease. It's a consequence rather than a cause. But human research and animal research have shown that inflammation actually indeed plays a role. But inflammation can be from many different factors. And what we think is one of the factors is the gut microbiome. So if we can make the gut microbiome healthy, we reduce the inflammation. So we are putting we just decrease the fire. Now, second question, how does the gut microbiome relates to inflammation? If you have an abnormal gut microbiome, your gut gets leaky. So all the bad bacteria from the gut, which generally won't get into your blood, gets into the blood and then stimulates your immune system. And then these immune cells secrete these abnormal proteins called cytokines, which can make the blood vessels grow. Okay, 2. 3, when we do a microbiota transplant, do we completely replace the patient's bacteria? It varies. Sometimes in some diseases, what we do is for microbiota transplant, like the native patient's bacteria always fight, and whatever we give is not taken up. The healthy bacteria is not taken up. So in some diseases, right now what's being studied is we purposefully give an antibiotic for a week. That antibiotic will destroy all the unhealthy bacteria they have. Then following that, we give the healthy bacteria. So all the healthy bacteria we give then is taken up by the recipient. So if we just give the unhealthy bacteria alone, not all of them are taken by the recipient. But if you give an antibiotic pre-treatment followed by the microbiota transplant, then we get a higher number in them. So there are different protocols. It depends on the underlying disease that, the protocol varies. I'll stop there. Thank you for the question.
I can chime in about inflammation and heart disease and cancer. So it's a little tricky to study this in patients who have cancer, in that cancer itself can sort of promote a very inflammatory milieu. I think there's a question in the chat about immunotherapy, which is kind of the prototype of an inflammatory condition, when we're talking about inflammation and heart disease and cancer. Immunotherapy, which essentially amplifies one's own immune system to go and fight against tumor by removing the brakes, can also cause what's called as myocarditis or an inflammatory process within the heart muscle. Thankfully, it's a rare problem, but can be a fatal one if it's not recognized. So it's very important to recognize that. The other advanced therapies, cell therapies such as CAR T cell therapy is also, it can lead to a condition called cytokine release syndrome, which is also a very inflammatory condition. So these are patients who are undergoing cancer therapies are also at heightened risk for heart disease, myocarditis, cardiomyopathy, arrhythmias, heart failure. But in terms of reducing inflammation and thereby seeing reduction in cancer and heart disease, it was very promising when we saw with the interleukin blocker when we used that in the CANTOS trial. But since the excitement has somewhat tempered over time. But I think if you take a step back, I mean, it's a shared pathway that connects the two entities. So by maintaining good overall health, eating healthy, controlling the risk factors, or avoiding developing any of the risk factors if we can, I think would go a long ways.
Thank you. Go ahead, Linyi.
Yes, so I do want to chime in on this topic of inflammation because I think it's very much in the lay press as a risk factor for adverse health outcomes like cancer as well as heart disease. So Dr. Conetti mentioned in a setting of very high acute inflammation due to the use of certain chemotherapeutic agents, there's certain things that we can do to try to curtail the inflammation. But I think it is the chronic low-grade inflammation that is what we want to try to prevent chronic disease like heart disease and cancer. And it is still the same few things, which is having a healthy diet. So specifically, diet that is anti-inflammatory, so that's rich in omega-3 fatty acids. So that can be found in fish, flax seeds, walnuts, for example. eating more antioxidant-rich foods, leafy vegetables and also fruits, and then avoiding pro-inflammatory foods, such as foods that are rich in trans fats. So these are found in processed snacks, fried foods, or avoiding processed meats. So we talked about diet, that maintaining a healthy weight. That is one important way that we can reduce this chronic low-grade inflammation. Exercising regularly, for sure. Moderate aerobic exercise that is regular can help to reduce chronic inflammation. Improving sleep quality, because poor sleep increases inflammation. Quitting alcohol, quitting smoking, limiting alcohol intake, and supplements have been tried. The data or the scientific evidence for certain supplements like vitamin D, magnesium, that remains unclear. And then finally, sometimes certain medications like cholesterol medications like statins can be used because they are known to have anti-inflammatory effects. But I would say that first and foremost, modifying one's lifestyle is a very good way, good effective way without resorting to supplements and medications to reduce chronic low-grade inflammation. Thank you.
Thank you. And this is a question to Suma. How do doctors, both cancer doctors and heart doctors, work together to balance treating both the cancer aggressively while also protecting the heart from long-term damage? And are there specific surveillance tests that you would recommend to those who are cancer survivors or who are currently undergoing chemotherapy or radiation?
Yeah, great question, and very pertinent to the day-to-day functioning of the cardio-oncology clinic that I participate in. So generally, I think recognizing, and this is actually from a very prominent oncologist who mentions this, is yes, we can give all the chemotherapy, but we know that we're inducing heart failure in cancer patients, and thank God for cardio-oncologists who can take care of them. And if they need more advanced therapies, we'll send them to you for them. So thank you for that. So I think recognizing that when we see cancer patients or we encounter that they are at risk for developing some heart issues, either weakening of the heart muscle or it's not 100%, but at least they are at risk for developing heart disease. And if there are risk factors, to optimally manage and control the risk factors before embarking on the cancer therapies. Most of the oncologists are familiar with referring patients for optimization of the cardiovascular status prior to cancer therapies. So I think we've come a long ways, I would say. Clearly, quitting smoking should be on the top of the list. In addition to adopting all the healthy habits that we have talked about so far. In terms of surveillance, I think most of the expert consensus has been after completion of cancer therapies, either after completion of radiation, chemo, all the necessary treatment, to obtain start with an echocardiogram to assess and get another baseline assessment of the heart function to make sure everything looks good. And from then on, I think it needs to be tailored. So folks who have received radiation therapy, most of the effects of radiation therapy is latent, so many years out, 10, 15 years out. So I think being cognizant of that and recommending appropriate surveillance, I would start with an EKG, an assessment cardiovascular exam. You can start with the primary care physician, make sure blood pressure is well controlled, there's no diabetes, the cholesterol numbers are well controlled. And an ultrasound about 10 years out from radiation therapy, I think would be a good start. There isn't a clear consensus on if we should do stress tests in patients who have had radiation therapy. I think, as I mentioned, the current day radiation therapy techniques are different than the ones from the past that have shown a very high risk of heart disease. So with the modern day techniques, it's unclear what the risk is. But certainly, if there are symptoms of heart failure, fluid buildup, edema, shortness of breath, chest discomfort, I think it would be prudent for the individuals to seek medical care and have an assessment done.
Thank you for that. And then a question to Linyi. You talked about in patients who have atrial fibrillation being at higher risk for dementia. Are there current therapies, whether it's anticoagulation, device therapies, that can reduce those patients who already have atrial fibrillation from going on to develop dementia?
Okay, thank you for that great question, Yes, indeed, studies have been published to show that the use of blood thinners or anticoagulants can reduce the risk of dementia in people with atrial fibrillation. So specifically, so 10 or 15 years ago, when we didn't have the newer generation of blood thinners, so patients were using warfarin, also known as Coumadin. Those patients who were taking warfarin at an appropriate dose and their blood is appropriately thinned out, they have lower risk of dementia compared to those who are not taking warfarin at an appropriate dose. So subsequent studies using the newer generation blood thinners have shown that when patients are very compliant with those medications, their rates of dementia are lower compared to those who are not compliant or not taking this medication. So clearly, if we can effectively prevent small little clots that may not result in a big stroke over time, that can reduce the risk of dementia. There are some reports of procedures known as ablation that patients with atrial fibrillation may commonly undergo, that if the ablation is successful in preventing atrial fibrillation, that might result in a lower risk of dementia, but the jury is still out on that. More studies will need to be done to validate and confirm those early findings. Thank you.
Thank you for that question. One last question to Dr. Thenapin. I know we're closing out on our time now, but could you talk about the role of artificial sweeteners in the gut microbiome? And for example, should people stop artificial sweeteners to reduce inflammation and promote gut health?
So I'm just not sure there's any direct relationship between artificial sweeteners and gut microbiome. But in general, processed food has been associated with an unhealthy gut microbiome. As Dr. Linyi Chen was saying, like green leafy vegetables, so unprocessed, healthy plant-based diet are the best for having a healthy gut microbiome. Avoiding any processed food, fatty diets, saturated fatty foods like Dr. Chen was saying, fried foods, processed chips, all those things would make your microbiome unhealthy. Artificial sweeteners, I'm not sure is there any direct link, but I would imagine, and I would be surprised if it's not associated with a bad gut microbiome.
Thank you so much. I'd like to thank all of our panelists for your time today and sharing your insights on the latest research and connections between heart disease and other conditions, as well as advancing whole body approaches to heart health. I'd especially like to thank all of you as our participants in the mini medical school today for joining us. We will see you next week for the third mini medical school session on the innovation and the future of heart care, which will be at the same time next Wednesday. We have an amazing group of experts that will discuss new technologies that are revolutionizing the way heart disease is diagnosed, treated, and managed. Thank you.